Assalamu alaikum. I think we should start now. If more people have to come, they can join us. I think today is my first session with you. So welcome to everyone. And I also want to apologize for the delay in my lectures. We were to start at 10, but then I was caught up in something, and then we had to change with Dr. Farhan. Sorry for this inconvenience. And these lectures are also included in your tomorrow's PI. You have gone through the infections of the stomach, small intestine, and these two lectures are pertaining to the large intestine. These are the intended learning outcomes. Just go through them. These are the learning outcomes for the lecture number 1. This is the brief characteristics of the infections which involve the distal part of the intestine, that is the ileum and the colon. The characteristics of these infections are different from the characteristics of infection of the small intestine, the portion above this. If you look at this slide, you see that there is disease is produced as a result of inflammation, and this inflammation is produced because of either invasion of the organism invades the mucosa or the submucosa, or there is some production of a toxin which in some damages the intestinal epithelium. Then as a result of this pathological process, there is production of mucus, and there could be, outpouring or presence of blood of some type in small quantities, or maybe sometimes in a little more larger quantities. And then there would be neutrophils or pus cells, as they are called. So blood, mucus, and pus cells are the characteristic of these infections, and these can be detected in the stool examinations. But this can vary with different pathogens. Some may have mucus, some may have neutrophils, some may have a combination of blood and neutrophils, some may have blood, mucus, and neutrophils, etc., etc. Diarrhea, as compared with the small intestine, originating diarrhea is of less volume. The quantity of stool is less as compared with the infections of the upper intestine. And they are this type of diarrhea is also named as dysentery also. Dysentery, when we say dysentery, we mean that this is a diarrhea in which there is blood and mucus. Now the infectious agents involved are, you can have a list here, are Salmonella, Campylobacter, Shigella, Entero-invasive E. coli, Entero-hemorrhagic E. coli, Yersinia and Clostridium difficile, and in protozoa, Entamoeba histolytica. You have already covered another protozoa, which is Giardia lamblia, in your upper intestinal infections. So having said this, having this slide background, we move on to the each individual path. Now, the first one is enterohemorrhagic E. coli. This is a gram-negative bacillus, facultative anaerobe. This is the characteristic which is common to the other E. coli also. And actually, these are different strains of E. coli. So, Escherichia coli has 4 or 5 strains which produce intestinal infections. Now, as like all the other members of Enterobatraceae, the organism has capsule, and this capsule has certain antigens, and they are known as somatic O antigens. And then there are antigens on the flagella which are known as the H antigens. Now, as a result of serotyping, this organism, enterohemorrhagic E. coli, has been named as O157H7. This means that 157 is the number of the O antigen on the capsule, and 7 is the number of the flagellar antigen, that is the H antigen. Now, sometimes it's also referred to as E. coli O157H7. In the cultures, the main difference with the other E. coli are, if you have really to identify this at the species level, all other E. colis can ferment sorbitol. Sorbitol is a sugar, but this enterohemorrhagic E. coli does not ferment sorbitol. So this is one of the differentiating features on culture examination of this. The patient will give you a history, often a history of having undercooked beef or other meat, water from unrecognized sources, unpasteurized milk, partially or uncooked vegetables, raw vegetables usually. And this is how it gets transferred into the human body. However, if it is cooked properly, as we do the cooking, or if the water is properly processed with chlorine and with other processing procedures, then this organism is destroyed. But in case of an undercooked food or unpasteurized milk or water which has not been properly treated, it can be transmitted. Now, the disease initially will present with watery diarrhea. Then afterwards, the watery diarrhea changes into bloody diarrhea. The blood becomes mixed with the stools, and in addition to this, this feature, there could be abdominal cramps, and fever is usually absent. That means that fever is not a hallmark of this infection. Rather, an absence of fever with bloody diarrhea will favor an infection of enterohemorrhagic E. coli. The main problem with this condition, as you've seen, is the loss of blood produced as a result of hemorrhagic colitis, and another condition which is known as hemolytic uremic syndrome, which is a complication of this enterohemorrhagic E. coli infection. Hemolytic uremic syndrome is present in a very few, around 5 to 10% of the infected children. But once it is present, then this is quite a dangerous condition. This is a disorder which is characterized by renal failure, thrombocytopenia, and microangiopathic hemolytic anemia. Now, the main virulence factor of enterohemorrhagic E. coli is a toxin which is known as Shiga-like toxin. Shiga-like toxin, and this toxin disrupts protein synthesis, and as a result of this, there is bleeding and there is hemorrhages into the intestine. How would you diagnose infection? You can have a stool culture examination, and if you find Escherichia coli inside, then you can, culture it on sorbitol agar, and you will find that this organism will not ferment sorbitol, and from there you can detect that this is E. coli, which is different from the other E. colis. So this is enterohemorrhagic E. coli. Then you can use different serological methods like ELISA for the detection of the Shiga toxin in the stool, not the organism, but the Shiga toxin in the stool. And then, the molecular method, DNA probes can be used for detection of Shiga toxin. So if Shiga toxin is there, that means that this organism is causing the infection. It is an indirect method of detecting enterohemorrhagic E. coli. Treatment is supportive. You don't need an antibiotic, because sometimes when you give an antibiotic, they cause too quick destruction of the bacteria, and as a result, a lot of toxins are released, and this may, worsen the condition, and it may produce hemolytic uremic syndrome, which otherwise would not have been produced. Now, before we go on to this Shigella slide, this toxin, this Shiga-like toxin, it is also produced by one variety of this organism Shigella, which we are going to discuss in the next slide onwards. And this toxin acts on the cells, and it interferes in protein synthesis, which results in the destruction of these cells. Now, the principal cells involved are the endothelial cells of the kidney, which lead to hemolytic uremic syndrome, and the platelets and RBCs. So all these three varieties of cells are mainly involved. The next bacteria is Shigella. This genus has 4 species: Shigella dysentery, Shigella flexneri, Shigella boydii, and Shigella sonii. These are present in different geographical locations, and out of all 4 produce dysentery. But the Shigella dysentery, the first one, also the dysentery basically produced by all these is invasive in nature. They invade the large intestine and bring about an inflammatory reaction. But Shigella dysentery, in addition to that, produces the Shiga toxin, which is similar to the Shiga toxin produced by enterohemorrhagic E. coli. So, by definition, Shigella dysentery is also capable of causing hemolytic uremic syndrome. I just wanted you to understand this. All general characteristics of the bacteria: gram-negative bacillus, 4 species, and they are non-fermenting colonies, and this will differentiate this from Escherichia coli, which are lactose fermenting colonies. Now, it's important to note that Shigella has a very low infectious dose, 10 to 100 organisms, whereas generally, the bacteria require large numbers to pass through the stomach and reach the intestine, and sometimes they need more than 100,000 organisms or something like that. But as low as 10 organisms in case of Shigella can produce a disease. This is important to note. After infections, it takes about 1 to 3 days to start the symptoms. And initially, the small intestine is involved, and as it spreads, then descends down to the colon, then it produces other symptoms like abdominal cramps, tenesmus, fever, pus, and blood in the stool, and there is fever as well. If you compare this with enterohemorrhagic E. coli, fever was not a common feature or a hallmark of enterohemorrhagic E. coli. Now, a few words about the Shiga toxin. Shiga toxin will bind to the M cells in Peyer's patches. I think you know what are M cells, right? And it's an A and B toxin. You know what's an A and B toxin? B part binds and A enters the cell. And this then produces the disruption in the protein synthesis. Now, this is the action of the Shiga toxin, whether it is being produced by Shigella dysentery or it is produced by enterohemorrhagic E. coli. When Shigella invades the epithelium, the intestinal epithelium, it goes into the phagolysosome of the macrophages, and then it escapes from these phagolysosomes, and this results in the apoptosis of the cells. But it can escape from macrophages, but it can't escape the phagolysosomes. So neutrophils are the main cell which is required to kill this organism. Humans are the only reservoir. No animal reservoir exists. This is also an important point here. And Shigella species is always transmitted from human to human. Now, diagnosis and treatment. Diagnosis, the first thing is the history. The pain, abdomen, tenesmus, the presence of blood with mucus, high-grade fever, and I tell you the patient is very, very severely ill. There are a lot of cramps in the abdomen, and really every time when he goes to the toilet, you see really he's wretched with pain and with tenesmus. I hope you understand what is tenesmus. Tenesmus is the griping feeling, is the knotty feeling or severe gripey feeling which is felt after the passage of stools. Now, having said this type of symptoms, and if the patient complains of blood in the stools, then the diagnosis is indicative of dysentery, and then you can draw a stool sample, take a stool sample and look, send it for microscopy, and you will see large number of WBCs and blood and mucus in the wet preparation of the stool, and then you can put it on the selective cultured medium, put on the McConkey's agar, you will find non-lactose fermenting colonies, and then with certain other biochemical tests you can recognize Shigella. And remember one thing here, that Shigella is non-motile bacteria, non-motile as compared with other organisms in the Enterobacteriaceae, which are mostly motile. Now, in the treatment, yes, you have to give pain relieving drugs and replacement of fluids. The fluid loss is not as much as compared with the with other E. coli diarrheas, or with what you have studied is what is that called? You must have studied in the previous lectures. Cholera. Cholera, yes. It is not as compared with these organisms, because fluid loss and electrolyte loss is more in the diseases of the infections affecting the small intestines. though the disease is also most of the time, self-limiting, but antibiotic is recommended because of two reasons. One is that it decreases the duration of symptoms. Now, symptoms are very severe. The patient is very, very ill. So you need to decrease the duration of symptoms. And secondly, by killing the organisms in this tool, you see, you are preventing the organisms to go into the environment and to risk the secondary spread. Now, the third organism on the list is enteroinvasive E. coli. And this is almost, the symptoms are the same as Shigella dysentery. But as this organism does not produce the Shiga toxin, and Shiga toxin also is only produced by Shigella dysentery, not the other three Shigella organisms. So the symptomatology is almost the same as the Shigella dysentery, except that uh, it can never cause hemolytic uremic syndrome, or the bleeding is not that much in enteroinvasive E. coli. This is a less common organism than Shigella, seen mostly in children. Self-limiting condition, not much of diagnosis is available. Then is Campylobacter jejuni. Campylobacter jejuni is a gram-negative Cocobacillus, which gives a gull wing morphology on gram staining. Gull is derived from seagulls. Seagulls are migratory birds which you see, which migrate from from country to country, and they land near the water sources, and then they migrate again. So they have a typical shape of their wings, and this is what that shape is, and this is known as the seagull morphology. This is very typical of Campylobacter jejuni. This is a common bacterial infection in the developed world. It is not passed directly from person to person. Food is the source of infection. This is again the seagull morphology. This is two seagulls flying together, and there's so many of them here. If you concentrate, you will find so many of them here. One is here, and then another one is here, and so many of them. 3-4 seagulls flying here collectively. Another one, very beautiful seagull here. So this is not very difficult. It is very easy to pick up. It is an invasive infection. It will damage, destroy the enterocytes, and starts at ileum, then down to colon, and then could also affect the jejunum also. So diarrhea, mostly it is dysentery type, but could be watery also. Blood and WBs are usually present, and it will behave like all other gastrointestinal diarrheas, but no hemolytic uremic syndrome. But although no hemolytic uremic syndrome, but there is an autoimmune complication associated with this, which is known as Guillain-Barré syndrome. This Guillain-Barré syndrome occurs as a result of cross immunity. Cross-reacting antibodies which produced against the organism can go and cross-react with the nerves. And this Guillain-Barré syndrome presents as neuropathy, which is glove and stocking type. Glove and stocking type means that it starts from the extremities and comes into the uh, body, starts from the periphery and comes into the body, and there is both sensory and motor loss. Now this is how it is acquired. It is acquired from the food, and the animals, they get contaminated by human excreta, and these organisms, they gain entry here. Then through these feces, the milk can be contaminated, and here you can well imagine that if you have an uncooked chicken, it is quite possible that it can transmit the infection onwards. Treatment, rehydration, replacement of fluids, and macrolide. Macrolides are erythromycin, azithromycin, clarithromycin. These are the antibiotics of choice. You would always start with a macrolide, and as an alternative, you can give ciprofloxacin. Now, the next organism on the list is Salmonella. Salmonella is clinically, it is not a species of Salmonella. There are about, many species, and then there are about serotypes. There are about 2,500 serotypes in this species, in the subspecies Enterica. Full name of this is Salmonella enterica, subspecies Enterica, and then there is the serotype, and there are so many serotypes. One of them is the enteritis. So there are many serotypes of Salmonella. You don't have to know the names of the serotypes. For your convenience, clinically, Salmonella are classified into typhoidal and non-typhoidal. Typhoidal Salmonella are Salmonella typhi and Salmonella paratyphi A, B, C. They produce a particular type of illness which is known as typhoid, and that is basically an infection of the reticuloendothelial system. There is sepsis, etc. We are not concerned with that here. We are concerned with the other group, which is known as non-typhoidal Salmonella. All the other serotypes are grouped into non-typhoidal Salmonellas, and this is just, you have to remember, typhoidal and non-typhoidal Salmonella. Non-typhoidal Salmonella produce disease which are limited to the intestine, and most of the time they are not invasive. They are invasive, but they're locally invasive. They're not invasive in the sense that they will enter the blood. Sometimes they do enter into the blood to produce bacteremias, but they do not usually cause septicemias and the reticuloendothelial infection as the typhoidal Salmonella do. Remember, typhoidal Salmonella and non-typhoidal Salmonella. Now, all these organisms, Campylobacter, typhoidal Salmonella, non-typhoidal Salmonella, Shigellosis, all these, they are quite similar to each other with little bit of differences. Now, from Campylobacter, you see the incubation period is different. Incubation period was similarity to Campylobacter is the incubation period, and the type of diarrhea which may range from watery to dysentery type, and then there is fever, cramping, etc., etc. And differences from Campylobacter are that presence of blood is a more constant feature of Campylobacter. The presence of blood is a less constant feature of this organism. And secondly, there is no Guillain-Barré. There is no autoimmune sequelae. Up till 8% of the patients, very few patients will develop bacteremia. Bacteremia means that the presence of bacteria in the blood, not septicemia. Septicemia is an infection of the blood. So they may present bacteremia. And this is more common in children and in immunocompromised people. So when bacteremia is suspected, then you give antibiotics. Otherwise, this is a self-limiting condition. Now, the problem with bacteremia is that although it doesn't cause sepsis, but the organism can, while circulating in the blood through different organs, can deposit in different organs and later on lead to problems over there. For example, some abscesses in the liver or in other portions, or if they settle in the bones, they can produce osteomyelitis, which is the abscess formation in the bone, the infection in the bone. So they can have their secondary effects in the form of these localized settling and then producing infection later on. Diagnosis of salmonella is based on the stool examination and then isolating the organisms. These organisms are also non-lactose fermenters. So in the stool, if you get non-lactose fermenting organisms, then you have to think between salmonella and shigella. Salmonella is motile and shigella is non-motile. And secondly, in some of the media used, the salmonella will give black colonies. Salmonella will give black colonies due to the production of hydrogen sulfide, H2S. This is not a feature of Shigella. So mainly you have to differentiate between these two organisms because they are non-lactose fermenters on McConkey's agar, and Shigella is non-motile, and this organism, Salmonella, produces black colonies. Then various other serotyping is done to differentiate within these species and subspecies of Salmonella. The serotyping is mainly for epidemiological interests. However, it doesn't have much effect on the management or the condition of the patient. Salmonellosis can be acquired from many animals, many pets, many farm animals, from the eggs also, from poultry, beef, and turtles, the domesticated turtles, house turtles, which they are, kept as pets. They are carriers of non-typhoidal salmonella, and you can get infection from all these people. So, with the first lecture here, any questions so far? If there are no questions, we can go on to the second lecture. Is that okay?
Doctor.
All right.
Doctor.
This is in continuation with the previous lecture. You are going to go through a different set of bacteria here. Listeria for one, Clostridium difficile for another, and Entamoeba histolytica causing amoebic dysentery will be the third organism that we are going to cover. Listeria is a gram-positive bacillus. Now, till now, what we have seen that all the organisms were gram-negative. Now, this is a gram-positive organism, and there's another very important feature of this organism is that it can grow and remain alive through a wide range of temperature. What is the importance of this organism being able to grow at 1 degree C? Anybody?
Maybe it can be growing in the refrigerations or refrigerators.
Yes, this is one problem here, that normally when we refrigerate the food and we bring it out, so most of the organisms are destroyed because the at 4 degrees centigrade, even at 4 or 5 degrees centigrade, most organisms, they don't survive. But this organism is especially notorious for the fact that it can survive at low temperatures, and especially if you use cold sandwiches and all that stuff like that, it can pass on very easily. It grows on blood agar and produces beta hemolysis. I hope you remember what is beta hemolysis from your pre-med. Typical example of beta hemolysis was Streptococcus pyogenes, but this organism also produces beta hemolysis, but this beta hemolysis is very weak, and its very small zone is there as compared with Streptococcus pyogenes. Then there is another important thing here is that this organism is motile, and it is less motile at 37 degrees centigrade, or rather non-motile, and more motile at room temperature. So this is one identification point of this organism. And secondly, the motility, even if you see at 37 degrees centigrade, it is not like other organisms. It is a typical type, and it is named as the tumbling motility. Tumbling means that if you are there's something wrong in the legs, or there is some weakness, then the person who has this weakness will move and then fall, maybe trip, maybe go sideways and then move again. So the motility is typically termed as the tumbling motility. It is not very clean, and this is a facultative intracellular pathogen as compared with others which were all extracellular pathogens. This is how it will look like. At-risk populations are neonates and pregnant women. Important. Then you have elderly, and you have people's, defect with cell-mediated immunity. It also interacts with the M cells and penetrates into the cell. Once it goes into the cell and it is taken up by the phagolysosome, the environment of the phagolysosome becomes acidic for the release of the enzymes. But in this acidic environment, this organism gets activated and it produces an exotoxin. And this exotoxin cuts through the membrane of the phagolysosome, and the organism is released out of the phagolysosome into the cytoplasm of the organism, where it survives. This exotoxin is called listeriolysin O. This is the principal, what is called the virulence factor of this organisms. Now, once it comes into the cytoplasm of the macrophages, it is no longer threatened by the enzymes of the phagolysosomes, so it can multiply there. And as the macrophages move through the body, so they can move and they can take this organism to liver, spleen, and other organisms as well. This organism has special liking for the central nervous system, the brain, and special liking for placenta. Now, its causing of diarrhea is of less significance. Its main significance is the production of symptoms in CNS and placenta, and it can lead to meningitis and it can lead to abortions. So that is why it has a very high risk in pregnant women and very high risk in neonate, because it is one of the organisms which is very strongly suspected in neonatal meningitis. The body responds with cell-mediated immunity. The humoral, the antibody immunity has very little role. Why the antibody or humoral immunity has little role? Anybody?
Because it is intercellular.
Very good, because this is an intracellular organism, as it does not come out of the cells, so antibodies, even if they are produced, will not be able to neutralize it. So basically, it is the cell-mediated immunity which is required to neutralize it, and Th1 type of response is required to activate and destroy this organism. I hope remember Th1, Th2 responses from your immunity. If you don't, then you must go and read. Now, as we just mentioned earlier, disease is seen in two distinct populations. One is the neonates and the other is the pregnant women. This is the most important group in which you must consider problems associated with this organism. Now, it is one of the three most important organisms which are responsible for neonatal disease. One is Escherichia coli K1 strain. Escherichia coli K1 strain. The second is Streptococcus group B, and the third one is Listeria monocytogenes. Now, Listeria can produce two types of presentations in neonates. One is called the early onset disease and the other one is called the late onset disease. In early onset disease, the infection is acquired while the child is still in the uterus, and this infection comes from the bacteremic pregnant women. And as we have seen, this organism has a great liking for the uterus, so it invades the uterus very preferably, and then it crosses the placenta and it enters into the baby, and it can produce in about abortion, can produce stillbirth or a premature birth. It can cause any of these things depending upon the age when it has caused the infection. You don't need to go into the details. All you have to remember is that the early onset, this you will be taught in your later on diseases of gynecology and all that. Now this you have to remember that in early onset disease, the infection is acquired within the uterus. Now the second type of the early onset disease is that infection is acquired not in the uterus but shortly after birth, right? But shortly after birth. Now if the infection is acquired shortly after birth, then the child is already born, so this will produce sepsis, septicemia, or meningitis in the neonate. Now the second type of presentation is the late onset disease, in which the child is infected 2 to 3 weeks after birth, and this infection can occur from the mother or from even the attendants. But usually, mostly, it is acquired from the mother at the time of the birth, but it takes this much time to present the disease. Now this disease will also present with meningitis or meningoencephalitis with septicemia. So if there is sepsis, then it is most likely it will come after 2 to 3 weeks, or if it is just plain meningitis, then mostly it could be from the mother. Now you see, it is present in a wide variety of the environment. It is present in mammals, birds, fish, etc., etc. So outbreaks have occurred with contaminated foods, contaminated milk, cheese, undercooked meat and poultry, raw vegetables, etc., etc. So you can also say that it is a type of food poisoning also in that way. Diagnosis and treatment depend upon the disease that is produced. If there's meningitis, then you can do a blood culture and CSF examination, but if it's just a septicemia, then CSF examination alone. And if it is a neonate, you can also take a swab from the cord, and you can find out if there is colonization. Now, treatment of Listeria monocytogenes is difficult. Difficult as most of the antibiotics, they do not kill this organism. And most of the antibiotics do not, this organism doesn't respond to most of these antibiotics. Those against which it gives response are usually bacteriostatic. So an ideal is that you combine 2 antibiotics to produce a proper desired effect. Now usually ampicillin or penicillin is combined with gentamicin, and aminoglycoside combining with a beta-lactam drug, and this is given over a prolonged period of 14 to 21 days. Now another bacteria, this is Clostridium difficile. This is also gram positive. So now we have 2 gram positive organisms. One is Listeria and the second is Clostridium difficile. But the difference is that Listeria is aerobic and Clostridium difficile is anaerobic, and it also forms spores, whereas Listeria doesn't form spores. It produces 2 types of toxins. One is an enterotoxin and the other is the cytotoxin. Usually the infection or the diarrhea produced by this organism in a great majority of the cases is associated with hospitalized patients, prolonged use of antibiotics, use of broad spectrum antibiotics. Now, initially, when it was recognized, the disease was first recognized, it was thought that it was produced as a result of the use of clindamycin. Clindamycin is a broad spectrum antibiotic, and it is still used, but it was in the past, it was very commonly used, especially in bone infections. And nowadays we see that many other antibiotics can cause this, especially the broad spectrum antibiotics like fluoroquinolones and cephalosporins. Now, why it is associated with antibiotics? When you give a broad spectrum antibiotic for a long period and the patient is also sick, is otherwise also sick and debilitated, what happens is that the intestinal flora is, you know, disturbed. Most of the intestinal bacteria forming intestinal flora are killed, and they are then this reducing of the intestinal flora gives enough attachment space to Clostridium difficile, and then this organism is in a position to produce symptoms. So, diarrhea produced by Clostridium difficile is also called as antibiotic-associated diarrhea. Just read these slides, which I'm missing. Okay, don't just skip them. That I have skipped them. Now, this antibiotic-associated diarrhea most commonly is seen in hospitalized patients. So this is a nosocomial infection. Now, along with this diarrhea, other symptoms are fever, abdominal pain, cramping, and there will be leukocytosis. A severe form of antibiotic-associated diarrhea is called pseudomembranous colitis. In this pseudomembranous colitis, if you look back, and we have seen these two toxins here, these cytotoxin here, this is produced in large quantities, and the infection remains untreated for some time, then there is a lot of necrosis of the epithelium, and these necrosis cells, they form a membrane on the inside of the colon. And if you look at this, if you examine the colon through a proctoscopy, you will see a pseudomembrane, a membrane which is not actually a membrane. Pseudomembrane means a membrane which is like the membrane, and this is present in a most severe form of this antibiotic-associated diarrhea, where there's a lot of exfoliation, a lot of tissue destruction, and a lot of bleeding, and cells are thrown into the intestine. This is the severe form. Now, treatment in antibiotic-associated diarrhea. If you suspect an antibiotic-associated diarrhea, in the earlier form, if you just you suspect because of the symptoms, because of the illness of the patient, because of the history that the patient is taking a certain antibiotic for such and such long time. Now, in that case, if you just stop the antibiotic, the patient will improve very quickly and dramatically. But sometimes, especially if there is pseudomembranous colitis, a simple withdrawal of antibiotic is not enough. So in that case, you would require some other antibiotic or some other treatment to control the infection. Now, in that case, metronidazole is the treatment of choice, or oral vancomycin is given. You have had antibiotic classes in pharmacology, didn't you? Anybody? Yes, you had. Now, can you tell me how, in which uh, condition you use vancomycin, and how do you use vancomycin? Yes or no? If you don't remember, it's all right. Just say no. Okay. When resistant gram-positive bacteria, yes, that's right. But typically, vancomycin is a drug which is only effective against gram-positive bacteria, and it is used against methicillin resistance. Somebody wants to say something? I can't hear it. The speech is distorted. Okay. It is given usually in methicillin-resistant Staphylococcus aureus or in resistant Enterococcus and in other gram-positive bacteria also. But the main thing that I want you to remember in case of vancomycin is that it is only effective against gram-positive bacteria. Never ever you should think of giving vancomycin in case of gram-negative bacteria. Second, vancomycin is not absorbed when given orally. In usual practice, it is always given in a slow infusion form through intravenous infusion, right? So in this case, it is given orally because we do not require vancomycin to be absorbed. We require vancomycin to act on the bacteria locally, right? And this should be enough for infection. Sometimes fecal transplantation of the normal flora of the intestine is also recommended. But this is in very rare cases, especially if there is a recurrence, multiple recurrences, and you think that giving antibiotics repeatedly is not feasible in these patients. So in that case, you can give the oral. You can transplant the fecal flora, and it helps by occupying the places and denying Clostridium difficile those receptors. Now, the last one, I quite understand that. How many lectures did you have today? 4. So 4, you mean to say 4 including these two? Okay, that's not much. All right. No, but you had 2 for microbiology, and you also had some pathology also. Three micro. Okay. All right. And 1 patho. Okay, fine. But that's not much, I think. From 9 a.m. Oh, poor creatures. Anyway, okay. This is the last one, and I will just not take much time on this, but this is important, right? Now, Entamoeba histolytica is, you can say it is a single cellular organism, a protozoa, and you have been introduced to another single cellular organism, another protozoa, that is in the duodenum, the duodenale sorry. Giardia lamblia. Giardia lamblia. Giardia lamblia caused watery diarrhea and it infected the uppermost part of the small intestine. Entamoeba histolytica is infecting the ileum and the large intestine. Entamoeba histolytica produces a disease which is known as amoebiasis, and there are two types or two varieties of amoebiasis. One is the intestinal, and the other one is the extraintestinal. And the most important or the common extraintestinal is the amoebiasis in the liver. In the liver, it forms an abscess which is called amoebic liver abscess. Intestinal amoebiasis presents with most of the time with watery diarrhea, small amount of diarrhea, small amount of water and feces in patient passes, and sometimes then it presents with a more invasive form with abdominal pain, cramping, blood even, and in this condition, this type of disease, which is known as amoebic dysentery, is quite similar to the bacillary dysentery. Bacillary dysentery means the dysentery produced by bacilli. Bacilli are Campylobacter, Shigella, and this non-typhoidal Salmonella, etc. So, but there are certain differences, but actually at the face of it, you may find it having similar symptoms. Now, this is the, in a very brief way, I will show you the life cycle of the organism. The organism exists in two forms. One is the trophozoite form and the other is the cyst form. Trophozoite form is present in the tissues, and cyst is passed in the feces, and this cyst is capable of surviving in the environment, and it can be transmitted from the environment back into the human being through water and through food. When the cyst enters the system, it goes to the stomach, and the effect of the gastric juice breaks down the this cyst wall, and as it passes into the duodenum, and it slowly starts existing. The cyst inside contains one organism with 4 nuclei. And now as it comes out of the cyst, as the cyst wall breaks, comes out of the cyst into the intestinal lumen, it divides into 4. Each nucleus takes some amount of cytoplasm and gets separated, and 4 organisms, they come out from one cyst. And these organisms, they come out and they enter into the invade the mucosa of the large intestine, and inside the mucosa of the large intestine they feed and they grow and they multiply as vegetative organisms, the trophozoites. But as they come out of these lesions back into the lumen, they can't survive the harsh environment of the lumen, and then they again form a cyst, and this cyst then passes out into the feces. Some trophozoites are also passed out in the feces, but they have a very short life. In about 5 to 10 minutes, they are totally destroyed. If you examine a fresh stool from a case of dysentery, you can see the vegetative forms, the trophozoite forms. And these trophozoite forms are motile, very slightly motile by throwing out pseudopods. They are very, very slowly motile. You have to concentrate very much to see, to find out whether this is throwing a pseudopod and it is moving. However, not more than 15 to 20 minutes they survive. and they die, and you can't really see a trophozoite unless and until the stool is very freshly passed. The cysts, they are tough and they can remain in the environment for even days. Now, as far as intestinal amoebiasis is concerned, the organism goes into the large intestine, and if you look at this, this is the section of a portion of the large intestine. This is the lumen, and this is the inner portion. It will invade into these, mucosa, through the mucosa, and will form ulcers here, right? All form ulcers, and inside these ulcers, these organisms, they multiply and they grow, and these ulcers have a typical small mouth where the organism enters, and then as it enters inside, the ulcer expands laterally, and this expansion gives it the shape of a flask. You know what's a flask? A narrow neck and a round body. So the ulcers of Entamoeba histolytica, histologically seen, are known as flask-shaped ulcers. Now, if the disease remains localized here, does not cross the submucosa, does not penetrate the submucosa, it remains intestinal amoebiasis. But sometimes, in some individuals, the organisms may penetrate through and through, and they may then gain entry into the portal circulation. And once they gain entry into the portal circulation, the portal blood, as it moves through the liver, the organisms get trapped into the liver, and they can then produce amoebic liver abscess in the liver. The organisms can also pass to other organisms like lungs and even brain, but the most common presentation is the amoebic liver abscess in the extra-intestinal amoebiasis. This is a larger view of the flask-shaped ulcer. What is the histology of it will later on, or already must have been described by Dr. What's his name? Farhan or Dr. Mansoor. This slide we have discussed on the first picture. You can just read this, so no need of duplicating again. Now this is important. Have a look at this. Just go through this, read this. This is a difference between amoebic dysentery and the bacillary dysentery. Now, a few words about amoebic liver abscess, because amoebic liver abscess is an acute condition sometimes, and it is sometimes a dangerous condition, and the patient is quite seriously ill. It is more common in men than women. Well, I don't know what is the reason. Well, generally speaking, we see that most of the diseases don't affect the women. I don't know why. For example, heart disease, hypercholesterolemia. So women are better off in this way. The majority of the patient will develop symptoms in 2 to 4 weeks, and usually they present with fever and pain in the right hypochondrium. Fever and pain in the right hypochondrium. Fever is high, there is rigors, shivering, the condition is very acute. Sometimes they may have cough because of the irritation of the diaphragm or the pleura. There could be nausea and vomiting and etc., abdominal pain. Now, if you examine there will be tenderness in the right hypochondrium, and you may be able to feel an enlarged, tender liver. Majority of the cases, the abscess is present in the right lobe. Most frequently, you will not be able to take a history of intestinal amoebiasis in case of liver abscess. But if you carefully ask the patient, you will definitely find that 6 months to 1 year or even more, he would give you a history of some type of diarrhea which was resistant and which kept on for quite some time. Because there is no other way that this organism can go to the liver. Humans are the primary reservoir. Highest incidence is in the tropical and subtropical region, for the obvious reason: poverty, uneducation, and lack of education, poor sanitation, etc., etc. Just one cyst can produce an infection. Infection is through food and water, and has also been seen through sexual malpractices, especially in homosexual men. Can be passed person to person. So this is what it is. Diagnosis and treatment. Diagnosis in case of intestinal amoebiasis, just in any other case of diarrhea or dysentery, you will take the history and then make a stool examination. Stool examination is very important in differentiating between the amoebic dysentery and the bacillary dysentery. Now, if you look at the previous slide that I've just shown you, you will find that in stool examination of wait a minute. That there is fresh blood seen in bacillary dysentery, right? But usually there is a darker blood seen in amoebic dysentery. Then you will see RBCs and numerous pus cells. Pus cells include neutrophils, numerous pus cells and RBCs. Now, in this case, you will see RBCs, clumped RBCs, some RBCs clumped together, eosinophils, numerous eosinophils, and you will see hardly any pus cells or macrophages. It is not that pus cells are not present because it does not produce inflammatory reaction. It produces an inflammatory reaction, but absence of pus cells in an amoebic dysentery is because of the reason that the amoeba at the local site destroys the pus cells. It causes destruction of macrophages and neutrophils. That is why it is given the name of entamoeba histolytica. Histolytica from histiocytes means that organism which destroys the histiocytes. Lytic means lysis. So this is a very important finding in the stool examination, which differentiates this from the bacillary dysentery, that there will be no pus cells in the stools. And then after this general examination, you can examine the stool for cysts and the trophozoite form. If you see a trophozoite form in the stool, then try to focus the trophozoite form, because if this is entamoeba histolytica, you will find an ingested red cell inside the trophozoite form, not in the cyst form, but inside the trophozoite form. Now, this ingested red cell is the diagnostic feature of the trophozoite form of entamoeba histolytica. There are another couple of trophozoites present in the intestine which are commensals, which are free living. We do not produce disease, right? So one of them, which is commonly present, is called Entamoeba coli. So this presence of the red cell within the trophozoite differentiates this from the non-pathogenic form, which is the Entamoeba coli. You will, if you see the cyst, you can recognize typically. And in case of, well, we'll see that later. Treatment consists of paramycin, idoquinol, and metronidazole and tinidazole. Now, this was the treatment that we have just mentioned in case, diagnosis in case of intestinal amoebiasis. Now, in case of amoebic liver abscess, there is no diarrhea usually at the time when the abscess is produced. So in that case, you will have to go and depend on the history, the clinical features, the enlarged liver, the tenderness in the right hypochondrium, high-grade fever, and then you go for imaging. Now, in imaging, all you can get is the presence of an abscess. You cannot differentiate this from the pyogenic liver abscess. Not on ultrasound, not on CT, not on MRI. So what you do is that you put a needle in this abscess, right, into the liver, and you draw a small amount of fluid. Now, in case of pyogenic liver abscess, you will find pus, gross pus. But in case of liver abscess of Entamoeba histolytica, you will find a chocolate, sort of chocolate-colored fluid, and which they say resembles a special type of sauce, which is known as anchovy sauce. I don't know, I've never eaten this anchovy sauce, but in the literature, the material which is drawn from the liver abscess of Entamoeba histolytica is known as resembling anchovy sauce. You will not find cysts in this anchovy sauce. If you are lucky, you may find some trophozoites, but usually the trophozoites are not present in the necrotic material. This is actually the necrotic liver material which comes out when you suck through the needle. The vegetative forms are present in the abscess, and these vegetative forms are very tightly associated with the wall of the abscess. Now, to aid all these findings, you can do a serological test. Now, serological test is positive in 50% cases of the amoebic liver abscess. If you find a serological test positive, you have the diagnosis. But if it is negative, still you cannot rule out the diagnosis of amoebic liver abscess. Now, remember one very important thing here: that serological tests are negative in the intestinal amoebiasis. They have no value in diagnosing intestinal amoebiasis. You can also do an antigen detection or PCR for Entamoeba histolytica on the material drawn from the abscess. Now, out of the list of the anti-amoeba drugs, commonly metronidazole is used, or tinidazole is used. Metronidazole you have to give in doses of, let us say, 500 milligram 8 hourly for maybe 7 days, 10 days, or even more. Whereas tinidazole you can give, I think, a single dose of 1,000 grams. Usually can eradicate the disease. Okay, I think that's it. It's enough. And if there is any question, please go ahead. Otherwise, we'll call it a day. And then you can go back and prepare for your PI tomorrow. PI includes all these lectures: stomach, intestine, small intestine, and large intestine. Okay, go ahead, please. Well, somebody has asked that why the neonates don't get disease in Clostridium difficile. All right, anybody who can answer this? Why neonates do not get the disease in case of Clostridium difficile? I think people are in a hurry and nobody is interested in staying
Doctor,
back.
because there is no receptor for
Yes,
the
yes, yes. In neonates, as the intestine are still under some sort of maturation stage, so as compared with adults, they do not have the receptor sites where this organism can bind. Thank you, Liam. Now, still, if there is any question or if you find something to discuss, you can use WhatsApp with me. I hope you have my telephone number. My WhatsApp is on the telephone number, and you can use that and send me a message.